to audio. Happy Thursday, beautiful people. We are gathered together for our collaborative planning and implementation meeting with the beautiful people of San Joaquin and Stanislaus counties. So welcome. Next slide. Most of you know the drill by now, but this is being recorded. So make sure you smile, say hi to the camera. Next slide. All right, so a few housekeeping items. If you can please update your Zoom name to include the name of your organization, that will help us. Describe how you are feeling using a type of weather, or if there's a favorite song that you've been listening to recently. I know that's been on my mind. And please feel free to use the chat, use the raise your hand function. We want to make sure that this is really a space for all of you to be in conversation, relationship, and lifting up the questions that you have. So please use your voice, use your chat, and raise your hand. Next slide. Okay. Bingo is currently Pauline's favorite song with 1.5-year-old. Oh my gosh, Bingo and Wheels on the Bus are not my favorite songs because I have had 1.5-year-olds. How about for others? Yep, Kill Bill by SCA, great song. Hours in Silence, Drake. SZA. Mommy row the boat with 4-year-old niece. Okay, you all are going to get some very bad songs stuck in my head. Is anybody new to this space? For anybody, is it your first collaborative meeting? If so, we want to give you a very warm welcome. Clear and sunny all day. Love it night. And for everyone else, welcome back. It looks like for everyone, welcome back. Next slide. Okay, we have established some group norms together. We want the safety to ask questions, clear and easy to understand information, room for fun while learning new information. Want to make sure that we have mutual understanding and that we give each other the benefit of the doubt, or do our best to assume the best of each other. A willingness to share our experiences with the group. The more we share, the better we become. This is not a space where you should feel like you need to be buttoned up and saying everything perfectly. This is really a space to learn, grow, and get clarity together. Openness. We're not going to avoid conversations. We're seeking to learn, not judge. Want to have space to connect. We want to support, have safety, and be honest about there being really different interests for participants in this collaborative, mutual trust, and collaborating. So again, a gentle reminder to update your Zoom name, although it looks like pretty much everyone has done it. And sunny all day, always and temperate. Okay, feeling sunny. Love it, Sadhna. Unstoppable by Sia, great song. All right, thank you everyone for having fun in the chat. Next slide, please. Our assumptions about who is here today. You represent a California-based organization in San Joaquin and/or Stanislaus counties. You're interested in or currently providing CalAIM services pertaining to enhanced care management or community supports. You have registered. We appreciate you for that. And we have this bolded that you are committed to improving the lives of Medi-Cal beneficiaries and collaborating with colleagues to achieve the goals of CalAIM. And we already know that to be true. We've been in sessions together, and your care for the people that you serve is really evident. Next slide. So here's what success looks like for today. We are going to launch a trusted messenger campaign, which is really about identifying trusted messengers that can spread CalAIM awareness. So we've talked a lot about, we've done all the work to plan a party, we throw the party, and then people don't know about it. People don't come, right? So we want to make sure that people in the community are aware of services being offered and being really intentional about the trusted messengers, organizations on the ground to spread that good word. We're going to continue with work plan implementation. For the implementation group who already has contracts, that's going to look like completing a journey map exercise, which is really looking at the end-to-end provider experience, and then to identify improvement opportunities within the experience. For the uncontracted group, or folks who are seeking to gain a contract, we're going to continue with our PDSAs and discuss the plan portion of our worksheets so that we can be moving to the do portion. And then at the end, we're going to ask everybody to self-select a focus area for your organization. Again, it's really important that we're tracking progress. And so that's the intent of asking you all to do that. Next slide. Today's agenda broken down a little bit more specific. We're doing recap right now. We're then going to move into identifying trusted messengers. And finally, we'll be in work plan implementation and close out with next steps and appreciations. Next slide. All right, who's ready for a recap? Hey, okay. Yes, thank you, emojis. Love it. Next slide. So we are in our 5th session today, if you can hardly believe it, how time is flying. In our 4th session, last time, we discussed the lessons that we've learned over the first quarter of this year and in our time together, excuse me. The shared goals. The shared goals that we want to achieve together this year, our timeline and our work plan for achieving those goals, the PDSA cycle and how it's going to really support testing our improvement strategies. And we also launched office hours for thought partnership and to provide coaching. And we're going to have an update today about how that first office hour session went. Next slide. So you can see here, there's an incredible group of organizations who have joined these meetings: California Association of Licensed Midwives, Community Medical Centers, HealthNet, California Health Collaborative, EA Family Services, Mariposa County, Transform Healthcare, San Joaquin Health, Gospel Center Rescue Mission, et cetera, et cetera. So incredible how this page of partners is filled, and just speaks to the good work that's happening in these counties to be in collaboration and be in conversation with each other. So want to applaud your work and the incredible participation. Next slide. Here's what you all have shared. This all should look very familiar about what the needs are. So in the first quarter, we really identified what are needs, what are areas for improvement. We've talked about the triple redundancy, the need for outreach and awareness. That's why we're doing the trusted messenger work today. Advocacy, rate viability, the need for upfront funding, having an intentional equity lens that's really focusing on smaller organizations, BIPOC-led organizations, having hub models, so there's really coordinated efforts, return on investment, making sure it's really a viable long-term business plan to be in contract. And then also a transparent needs assessment about what folks are needing on the ground and making that information really accessible to all and not needing to make guesses around that. Anything that you all have shared that you don't see reflected on this slide or that you would like to add? All right, good. That means we have captured it. Next slide. Okay. So to recap our goals, The first one is for organizations who are contracted by December 31st, contracted providers and organizations that work with contracted entities in San Joaquin and Stanislaus Collaborative will work to advance the sustainability of community supports and enhance care management programs by adopting improvements that address the triple redundancy, which is administrative and procedural issues embedded within the referrals, authorizations, and claims process. And that all of that work is going to result in 75% of committed participants implementing at least one key action to improve CalAIM implementation. So that's how we're going to measure success for that goal. For folks who are seeking a CalAIM contract, that 75% of uncontracted organizations who are eligible ECM and CS providers participating in this collaborative will have advanced at least one stage in the contracting process. And we know that that's 4 stages. So depending on where you are, you will have advanced at least one stage. Okay. And the objectives are really to identify trusted partners to increase CalAIM awareness, objectives for today, excuse me, measuring progress towards goal. We want to chronicle systems level changes. We know that this collaborative is about making changes now so that things move more smoothly and we're better able to serve, and that there's also longer term system level changes that need to happen. And so making sure that we are making the changes we can now, and also really making note of what those long-term system change efforts need to be, and better understanding the provider network. Next slide. Okay. So here's the timeline for our work. On the top in the kind of peach color, that's the implementation work group. That's folks who already have a contract. Below is for folks who are interested in getting a contract. So for the implementation work group, there's 4 phases. Already have completed the first phase, well done, which is the problem identification. Now in phase 2 of data collection and analysis. And that looks specifically like adopting an improvement area, journey mapping to really understand where some pain points are in the process, and identifying process gaps, so that in July in phase 3 can really move towards solutioning, which looks like process recommendations, process adoptions, and outlining those through PDSAs. And finally, in the last quarter of our work for phase 4, it'll look like testing and implementation. So measuring progress, making sure that we're chronicling best practices, busting through the barriers that we've identified, and making system level recommendations. For the uncontracted work group, the work is broken out by quarter versus phase. So we've also completed phase 1, well done, problem identification. We developed shared goals, we determined some changes that are needed, and we also designed how we're going to measure progress. We're now in quarter 2, hard to believe we are in June, and we are looking at adopting a test of change. So looking at where you currently are in the process of becoming a contractor, adopting a strategy to move towards the next phase of having a contract, and again completing the PDSA model to create the plan for implementing. In quarter 3, we will identify themes and really busting through barriers related to these problem areas that have been identified. So the return on investment, the equity, provider education, and funding. And in quarter 4, we're going to be really looking to identify best practices by monitoring, measuring progress, chronicling those best practices, and again, making systems level recommendations. Let me stop because that's a lot and just see if there's any questions, clarifications, celebrations. Okay. Forgive me, my allergies are giving my throat a tickle. Okay, looks like we're ready to go to the next slide. Okay. Was anybody who's in the collaborative right now attended the office hours that were held? Hey, Davion did. Was anybody else able to join? Casey? I like how the thumbs up emoji now is it's like a very pronounced thumbs up, you know? Did I see Eliana with a hand raised? No, that was a heart.
Yes, I was there at the office hours.
Cool. So would love to hear from Casey, Eliana, Davion, any reflections that you have from attending office hours?
I can share a little bit. I had the opportunity to attend the office hours, and it was a small group, which I think it really helped with some of the organic discussion. There was a provider, a current ECM provider, that shared some of the best practices as to how they're implementing ECM, and some successes with that as well. So I think what we took back from that conversation was that it's important to highlight experiences by the providers that are, doing the work on the ground, and how do we highlight and spotlight some of the best practices, really the collaboration that's happening. It's really due to the services and the knowledge of the local need, right? And I know the providers here on the call now, and I don't know if they want to share additional information, but it was really helpful on the plan perspective to hear how the ECM services and program is being operationalized on the ground. So that was great insight for us.
That's great. Thank you, Eliana. I appreciate that. How about for Casey or Davion? I hope I'm saying your name right.
Sorry, I couldn't find the unmute button. I'll have to be honest, I felt kind of shortchanged, and it wasn't because the quality of the meeting. It was more, I left one meeting late and then had to race off to another meeting, so I didn't really get to be on there like I really wanted to. But at least while I was on there, I was hearing good information about how at least one of the current providers was doing and processing things. I know for me, it would be great to be on another one where hopefully more providers or managed care plans can be on there, so another discussion can continue to happen around it.
Right. That's really good feedback. Thank you, Casey.
And then my name is Devin, by the way.
Devin, thank you.
And that meeting was great. I think we had a lot of good information, and Eliana also had some input at that meeting. So it was really great to hear from the managed care plans perspective. And aside from that, I think doing those more frequently, I think those would be amazing.
Great. Really, really helpful feedback. There's another one coming up on June 15th at 1 p.m. You'll get this slide deck, as you always do, after the meeting, and there's a link here on this slide to join. And also hearing that more of them would be helpful, and that having providers on the call was really beneficial. Some of the things that came out of the office hours where folks were really able to coach one another through the billing process. So sharing how to correctly bill for HPSJ for community support services, including in what increments, how to document case management, and how to determine codes. There was also a proposal made and a recommendation for how to improve interagency referrals, uplifting the vitality of interagency referrals and the need to better understand the provider network in order to better comprehend who can send and receive referrals. And there was a question about, can an in-person convening support this? And then there was also a couple of proposals made. One, that there be a new ECM population for Medi-Cal, and it's for beneficiaries experiencing catastrophic diagnoses. And then also continuing education, proposing a CalAIM continued education credit for all Medi-Cal serving providers in order to increase CalAIM awareness and beneficiary knowledge. Yes, Casey. Did I see you with your hand up, Casey? Am I making that up?
Yes, you did. I apologize. I completely forgot that I was on a virtual meeting and had the mute button on. I don't know. First time here. Sorry.
Welcome to Zoom. Not at
Yeah, I apologize. This is my
Not at
first time,
all.
I swear. This is brand new to me. The question that I was trying to say that no one heard on him was life-changing. So I'm sorry everyone missed it. We're working with another county provider and they have 4 categories. But my concern and challenge is they have a catastrophic category, but they're also stating those individuals that fall into a low acuity tiering wouldn't be eligible for services. So I guess I'm looking at it as it gets a little confusing because DHCS has the 3 categories, you know, high, low, medium, but by adding a 4th, it's almost like those that would naturally fall into a low naturally aren't even eligible for services, period. So are we recustomizing the intent of ECM for the focus populations? That's what I'm just trying to figure out how we could make that work to where we're doing a catastrophic when we already have a high category.
I'm wondering if Sedna or others have thoughts about this.
Hi, Ashlyn. Sorry. Could you?
Hey, Sedna.
Yeah. Hi. Could you? And I see Alexa's chiming in on chat, so I'm going to kind of pause
Okay.
for the reframe on the question.
Casey, would you be willing to name it again?
Yeah. So is it really beneficial to have a 4th acuity tier category of catastrophic, given that if they qualify as a low acuity level, even by a current provider we have in Sacramento County, they wouldn't be eligible for services. So is it really in our benefit to add a higher level and just anyone who's in low not be classified as eligible for ECM services?
Yeah, I think we need to kind of offline this into, this sounds like a really technical piece, and I think it's a good conversation for the contracted group to kind of take on and see kind of what is the process pain point here.
Right.
I think I understand, Casey, kind of what you're talking about. I don't have like the level of expertise on like the acuity levels and how it's trickling down, but I think it is a good point for discussion within our contracted group to see kind of how it's playing out for folks and be able to identify the solution. I think that's you're offering a solution here. And it might be a little bit of a conversation along with the plan.
Yeah.
And I'm completely open to that. Yeah,
Great. Thank you, Casey. Thank
of
you.
course.
And for the
Can I add something to
Yes.
that real quick?
John, yes.
So when we're working with people through ECM and through CS, we work with all different types of patients of different acuities with their medical conditions, whether they're on dialysis, whether they're somebody that has asthma. We work with the whole spectrum of people. It's based off, when you're working with somebody with ECM, it's based on what they qualify through ECM through, and that can be a high utilizer if they're going to the ED 3 times in the last 6 months, or being hospitalized 5 times in the last 6 months. If they have a chronic condition, whether it be medical, physical, or behavioral, and also be homeless and unable to sustain, or unable to successfully sustain their current situation. So they're really, when you're getting somebody enrolled into ECM, the acuity of that person's medical condition or behavioral condition, it just has to be complex, whether it's from one side of the spectrum or the other. It just has to qualify that criteria. So I don't see it on my end when I'm enrolling somebody what level they fall under, whether they're going to need less case management because of their level of medical intervention, or somebody that's on dialysis every 3 days a week, or somebody that has chemotherapy, or that's, you know, what their medical condition is. It's just based off how they qualify for those services through ECM. And I don't know if I answered your question or not. I apologize.
Thank you, John. Yes, Casey, let's get your response, and then let's keep, and Eliana, and then let's keep moving. Maybe this does make sense to pick up in the breakout. But yeah.
Then I will leave it at that, because yeah, I know we have time sensitive and I want to be mindful of what we're trying to accomplish today. So I will leave it at that. Never mind. Thank you.
No, it's quite all right. Thank you, Casey. Eliana?
I don't want to take too much of the time. I know that there's a full agenda, but I think in the health plan perspective, at least my understanding is that tiering system is just it's a way to identify the need. And I think John touched a little bit on this, and that need could change, right? It could be a newly enrolled member who then after a month or two are doing really well. So that tiering system can really change month to month for a member. They can go into crisis and they can feel better. They can, you know, within 3 months, their A1C, their diabetes numbers could improve. So that tiering number is just more like a guidance as to how the member, or the frequency, how often the member should be contacted or work with. But on the health plan perspective, at least on our end, we don't prescribe. So if you have to meet with them 4 times a month or 4 times a week, it's really based on we leave that up to the provider and their own assessment of the need of the member. It could be that you need to meet with this member every single day, but it could also be that as their condition improves, you scale back a little bit. And I think we can share a little bit more of that if this conversation is taken offline as to how we see it on the plan perspective.
Wonderful. Thank you. All right, let's go to next slide. All right, so we are going to move into trusted messenger, aka rapid prototyping, which is about building something that's really useful and building it very quickly. Okay, so in order to do that, we're going to go to the next slide. We're going to give you a couple of ways to participate. Okay, but here's the question. Who are some of the trusted messengers in our communities that we want to name and really begin to chart on paper? Okay, or in this case, on a Jamboard. So who are the trusted community partners that can help us to spread awareness and education? So in order to do that, we are going to launch a Jamboard for you all to see online here. We're also going to share the link to the Jamboard in the chat. So if you want to, if you're very comfortable with Jamboards, you can use the link and fill things in on your own. Or you can just name things out loud, put them in the chat, and they'll be populated onto the Jamboard for you. So we will give the amazing Shiva just a moment to transition the sharing from the PowerPoint to the Jamboard. Great. And you can answer any of these 3 questions. They don't need to be in a specific order. Who are the trusted community partners that can help increase awareness? What is the message we want to share? And who should own really engaging these organizations? Okay. And is the link to the Jamboard in the chat yet? Great. Thanks, Alexis. All right. So here we go. Just for the sake of clarity, let's start with who are trusted community partners that can help increase awareness. And don't worry if it's something that we already know or is already tracked. Let's just go ahead and put everything out here that you can think of. Yep, so it can include schools, community centers, childcare centers, recreation offices, YMCAs, community organizations. Yep. Schools, excellent. Yes, barbers, hairstylists, receptionists, and faith-based leaders. Excellent. Local rec centers such as Maddox in Westside Modesto. Hmm. So are there specific schools that we can begin to name, like a specific rec center was named? Specific community centers, specific hairstylists even? A lot of times too, this is Alexis, who said it's so hard not to be able to speak. We will make sure your voice is heard through the chat, Alexis. I'm sorry, I did not mean to laugh at your pain. So another one is a lot of times this can be local restaurants, right? That we all go to, a local coffee shop or cafe. You know, are there specific places located near the schools that kids are going after school? You know, a bobo shop, great. Orville Waite is a local school that also offers free mobile farmers market. That's great. And that attracts local families. If there's specific, I think, if there's specific faith leaders, I think faith leaders was named, but isn't yet on the sticky notes. Receptionists. So what's the message that we need to share? So we've gotten all the trusted messengers everywhere that people go in all the different areas. They are going to get the information that they need in order to access the best care that they can. What do we want them to know? What's the information or the message we need to share? Yep. So we want them to know what services are available, how to qualify, how to access them. We want them to know that there are no barriers. So we want them to receive the message that this is an easy process, right? That part of accessibility is the process being easy, how to connect. Yep. Yep. Any other messages that we need to share? What about that they are cared for? That providers want to see them. Yeah. To feel a sense of belonging. To be able to see all the different organizations that are collaborating. Yep, to see that this is, to receive the message that this is coordinated and expansive. Great. That you're not alone. Yep, absolutely. And then now to this third part about who should engage these different organizations. Another way to say this is who is already engaged with some of these organizations and already have a connection. So if there's trusted messengers that have been named here that you are in relationship with, if you can put that in the chat or come off mute. This is always the tough part, right? We're all like, not it. We all already have so much. Okay. Well, I think this is, yes, please go ahead, Samantha.
I was just saying, who should own engaging these organizations? I think everyone. We already have partnerships. Some of us, most of us, all of us have partnerships already in the community. And so if we have direct partnerships, sorry, I'm not coming off camera. I got a lot
That's
going
all
on.
right. That's all right.
Now, sorry.
No, you're good.
But I'm thinking that we here already in the community have partnerships that we made. So it's our responsibility to educate those partners that may not be aware, you know, and have them come on board with us and help with spreading that word.
Yep. Love that. Thank you, Samantha.
I think engagement also, it's kind of should be a collaboration between the managed care plans and the providers, depending on the level of who we have collaborations with previously. So, you know, managed care plans have a wide breadth of understanding who the physicians are out there, private, specialized physicians, which I may not know of. And, you know, I would love to get my information out to them in regards to the community support services that I provide, not only to our clients and our clinics, but to Health Plan of San Joaquin members in general. They don't need to be part of SJ Health Centers to receive community support assistance. And a lot of the masses through private doctors, through specialty clinics, may not know that information. They may only see it as they have to be connected to a specific medical organization to get services. So the managed care plans would have that, I would say, information to be able to provide that level of communication with those people. And then on our end, we would be able to reach out to our members in our community when we do outreach, when we work with shelters, when we work with food banks and other agencies that we currently collaborate with. And so we're attacking it from all different angles. It's going to take just people at different levels to be able to get this information out to the masses. And so a collaboration between the managed care plans, ourselves, and other different agencies would be the best probably approach I would take.
Yeah, yeah. So consistency, coordination, and to Samantha's point, really intentionally engaging with those already in relationship with. Let me do just a quick poll on Alexis's question about, do you all think it would be helpful if we had one of these collaborative sessions be a space to engage these trusted members and community messengers, and community organizations and leaders? So you can go ahead and respond to that in the chat. We're getting a heart from Samantha. Wonderful. Okay. I'm aware of time. This is an exercise that is not one time. We're going to come back to it. This will be a reoccurring theme. And let's go ahead and go back to the PowerPoint now. Go back to the last slide. Thank you all for engaging in that. I think we made good progress. Okay, so let's get ready to implement our work plans. Next slide. You all know the drill by now. There's 2 breakout rooms. So breakout room A is for contracted organizations. Breakout room B is for folks who are not yet contracted and are seeking a contract. And we are going to have 30 to 35 minutes in the breakout room. So I'm gonna invite everybody to, 1, be really engaged, and also to make sure that we're leaving space for everybody to get their voices into the conversations. Sound good? Okay. Then let's go ahead and get moving into breakout rooms. So again, breakout room A is if you have a contract. Breakout room B is if you are not yet contracted. And you can just click on the breakout rooms button and click whichever room you want to join. And I'll monitor the main room. So Teodros, you can go ahead and go to the breakout room. Hi, Pauline. Oh, it looks like Eliana did just go to our room. Okay, so let's go ahead and go to our breakout. And then we'll obviously move through it pretty quickly, and then we'll go ahead and join the contracted group. Sound good?
Sounds good. See you there.
See you there.
Here, Shiva. Okay, so Shiva's here. Shiva will, I think, get our PowerPoint up in a moment. Are folks excited? We've got a debt limit deal. Anyone excited about that? Maybe John. I'm not referring to Congress. I'm actually just talking about my wife and I in our house. So Congress, I don't know if they've passed it yet, but we'll have a decent Christmas in my house. Okay, so let's go ahead and get started with where we left off from last time, right? We had good to see you, Samantha. And I don't think this was a secret for anybody who was at our last session, but we were trying to reverse engineer the referrals process, right? The workflow surrounding referrals, authorizations, and claims. We had some problems with that. That didn't quite work out the way that we wanted. I think we realized that there isn't really a set process, and that it doesn't flow in a linear process. And so, we know that folks had trouble identifying the specific kind of pain points. And so we're going to be taking a different approach today. We're going to actually do a journey map. Okay. And, the way that's going to work is, we're going to use that to try and just understand procedurally what are the various points in the process. And then hopefully from there, we can identify improvement strategies, okay? That's, I think that's okay that we couldn't initially reverse engineer the process. I think that actually gives us an opportunity to try and create something that is, more not just realistic of what happens, but maybe even more ideal, because we can plug in different parts to the process that maybe should be happening or could be working better. So why don't we go to the next slide? Okay, so when we talk about journey mapping, right, what is a journey map? Right, I know there are a lot of folks who probably haven't heard that term before, or not familiar with what that means. But a journey map is essentially just a visual representation that depicts how a user or customer interacts with a product or a service or a process. I think for today, we're going to be taking the ECM perspective. We'd love to include the CS perspective, but we just don't have enough time to do that today. So we're going to leave that for, I think, the CS perspective for the next collaborative. But focusing on the ECM perspective, and what are they thinking? What are they feeling at each stage of the journey, right? So this will help us hopefully understand, need, pain points, overall experience, right? And enable us to improve the process based on those observations that are made. Any questions about that? Okay, next slide. So we'll just spend a few minutes going over the process overview. Okay, what we're really trying to do here is, just go over the process from start to finish and get your reflections. We're not going to kind of discuss problems on this slide. We're going to do that on the next slide. But let's say, from the beginning, number one, we've got a member who's referred. Greg is identified by the plan, and he's either a self-referral or from a provider, right? So either his file is created, or the ECM provider reaches out to Greg to schedule services. Okay. If Greg is not engaged, that's a different process. If he is engaged, then he decides hopefully to enroll with the ECM provider. The provider updates the file, and then the provider submits the authorization to the plan. Okay, going back a step, if Greg cannot be reached or decides not to enroll with the ECM provider, the provider updates and closes the file. Okay, assuming though that he has decided to enroll and the provider has submitted the authorization to the plan, the next step is the authorization approved, right? If not, then the member is referred for other services. If he is, then services rendered. Greg receives services, the provider updates the member file, and then the claim is submitted, right? The provider submits the claim to the plan. So that is the overall process that we're looking at, from the member being referred to outreach to enrollment, authorization, service being rendered, and the claim being submitted. Any reflections on this? Any observations? Let's see, I have a comment here from Ileana. As of January 1st, 2023, if a member is identified on the monthly MIF HealthNet, does not require the provider to submit an authorization. Oh, interesting. Okay, I did not know that. Great, thank you, Ileana. Okay. Any other questions, observations, thoughts on this? Eliana, Alexis is
Okay.
asking if you could
Yeah.
speak to that.
Yeah, definitely. I'll say a little bit more about that. Thank you for asking, Alexis. So what that means really, by removing the need of the authorization, the provider is able to immediately after they receive that MIF on the 15th, begin services if they're able to make contact with the member and not have to wait for that lag time between requesting the authorization and the authorization being approved. So let's say if someone's identified on their MIF, they're able to start services right away if they make contact with the member. They can start invoicing right away. We don't have a scheduled invoice time. They can schedule at any time throughout the month or when those services are rendered. And really, the goal is to help the process move along and not delay the services to the member in any way. Casey, I see you have a question.
Yeah, no, it's not so much a question. I think the part of the challenge is we have essentially two different sources. We have from the plan, which we get the MIF list of those members that are already eligible. And then we get someone that has been either self-referred or from the community has been referred into the program. So
yeah,
the process is almost, what you have here is the process for like a self-referral or a provider. And then what we have is the plan. We're getting those that are pre-approved from an MCP.
mm-hmm.
And I can agree with the self-referral and the provider. This to me seems pretty much exactly like the process. I'm not an expert in the room, but I would say it doesn't seem like there's any steps that are left out, because then the next process goes to like working on an intake and then the assessment and then the care plan. But this is the process when it comes to a self-referral or a referred from a provider, or I'm not a provider, but CBO, sorry. Couldn't figure out the alphabet soup I needed to use.
So Casey, I think Alexis was posing the question of, does there need to be a third tier for the pre-approved list?
I wouldn't think so, as we have the process. If they're on the MIF list, then they're approved. If we've received the referral from, at least from my personal perspective, let me just speak for myself. If it's coming from a self-referral or a CBO, then I don't see that there's any other, this is the process that we've been directed by MCPs to follow.
Okay.
And again, Nye or Ileana, or if there's any other MCP on the call, please correct me if I'm wrong.
Yeah, no, this is definitely the process. I can speak on the health net side, right? And I think for some providers who are multi-county and you deal with a lot of different plans, the process will look a lot different from plan to plan. So I think at least on the health net perspective, right, there's no authorizations as of 1/1/2023 for those who are identified on the MIF, but the bottom up referral for those that you're identifying as being referred outside of the MIF, right? That process is a little bit different and it does align with what you have here. We do encourage providers to, once they're getting that referral, that they're checking the provider portal, making sure that that member is eligible for services or at least eligible for Medi-Cal. And they could do that with, I'm not going to speak to the health plan of San Joaquin side, but for the health net side, making sure that that member is not already enrolled with another ECM member or provider and that they're eligible for Medi-Cal services. And at that time, there's a referral form that has to be submitted and some additional documentation. We don't require the authorization at that point, but there are some steps to follow to make sure that we have the line of sight that provider is not working with that member.
And if I could just jump in real quickly, I know that, there are probably more points of this that folks like to discuss. We're limited on time. And I apologize, Casey, if you'd like, you can put your input into the chat box. Anybody else who'd like to put their input in or observation, please put it in the chat box and we'll acknowledge it. But we've got to get to the meat and potatoes of this next section. So let's go to the next slide, please. Okay, we just went over the ECM process overview. Okay, so now let's actually get into the journey mapping exercise. Okay, so we want everyone to actually, let's just go ahead and click on the journey map link. Okay, great. So no, that's a referral site. So we're bringing up the journey map. We're going to go over and maybe a little bit more quickly than we were originally planning, but we're going to do the journey mapping exercise and we're going to collect data from everybody on each of these sections. We're gonna share this data out with everyone. Okay, after we've had a chance to talk to the plans about it and develop process improvements. But let's start with the first box, which if we're talking about sort of the emotional experience at each phase. And so if we're talking about the member referral, why don't we have folks take a few minutes to think about as specifically as possible the issues that you're experiencing. Okay. For example, if the MIF is incomplete when received. Does that make sense? So the journey map, and you'll see the journey map link in the meeting chat, so you can actually pop that open and fill out your response to that.
Hey everyone, Alexis here. I'm so sorry that you all have to hear me right now. I have laryngitis, and so you have no idea of how difficult it has been for me not to speak during this meeting. It has been literally tormenting for me for days now. But I know that for some, the journey map is going to be familiar, while for others, the journey map is going to be unfamiliar. So following up on what Teddy just advised, we're going to just spend about 5 minutes going question by question, even though in front of us, it seems like, this basic spreadsheet. By the time we, finish completing this document, it is really going to give us, a bi-county-wide understanding of where the specific pain points within this entire end-to-end process are. And that is very, very valuable information that we can then take back to Health Plan of San Joaquin, back to HealthNet, and really identify the specific pain points within the process based off of this feedback that you're going to provide. And so we're going to start off with this emotional experience and what you perceive as the provider, what you experience, across each one of these touch points. So for that first question, what is your emotional experience at each phase of this process? What you're going to do is you're just going to either voice over or put it into the chat for us, or, go into the spreadsheet yourself and just make the edits just to let us know. For member referral, is it green? Is it gray, which is neutral, or is it red, which is bad? For receiving the MIF, is it good? Is it neutral? Is it bad? For outreach, what is that experience? We have, our own assumptions, about what we think, right? Based off of what we've discussed to date, but we just want everyone to either voice over or go into the document and just place an X, like for that first question next to what your emotional experience is. And so we can just spend about 5 minutes. And if that's not clear, just please feel more than free to ask, any clarifying questions, and we'll just need your response for each one of those touch points. So for member referral, for receiving the MIF, for outreach, for enrollment, for authorizations, for claim submission, and then for reporting, what is your emotional experience? And then once we finish that first section, then we'll go into the next section where we'll actually discuss the specificity of those issues. And sorry that y'all had to hear me sounding so crazy.
Okay, so folks have a few minutes. Let's just give you 3 or 4 minutes. Does anyone need more time on this one? I think Alexis is actually asking for some feedback because someone asked or stated that their feeling was mixed for enrollment. I'm not sure who did that, but could you give some feedback on that? Okay, please provide feedback if you haven't already. Okay, I think Casey answered the question by stating member enrollment is mixed due to some members wanting services, not understanding services, and not knowing enough about services. Alexis, can we move on to issues? Okay, great. So let's go ahead and move on to the issues column and give you a few minutes to fill that out for each, or the issues row, and give you a few minutes to fill that out for each column.
I apologize. You said the column?
Well, the
Row.
issues row, and then if you could fill out your answer for each column.
Perfect. Got it. Thank you.
Thank you. Okay, I think Samantha had a comment here about the platform use doesn't always work for us. STFP, we will get an email stating something has come through, and when checked, it is empty. Okay. Thank you for the comment, Samantha. Hopefully, folks, if you have not already, go ahead and please fill in your answers there. John stated member referrals, no issues. MIF, not having current contact information. Outreach, no issues. Enrollment, no issues. Authorizations, no issues. Claims, our issues. Our coding needing to be added to the platform. Okay, great. And Alexis is capturing this in the spreadsheet. So does anyone else need more time on that? Can we move on? Is that all right, Alexis? Can we go on to interactions? Okay, so we're going to stay here for a minute longer. Samantha said claim submissions, they get repeatedly denied when they should not be. Samantha, do you want to add anything to that in terms of, maybe some examples of, when they're getting denied and they should not be denied?
Yes, sorry, I have someone on the phone with me that handles our referrals, so I was trying to hear what she had to say.
Oh, okay, that's fine.
So, yeah, so what Ari said was that we'll have the 4 required meaningful, for example, we'll have the 4 required meaningful touches on a member. They'll have been correctly authorized, and then they'll be denied with no cause.
Oh, okay. All right, we'll make sure we'll take that feedback down. Okay, folks, we still have a couple of more important rows to get to. So, and I'm sorry, Samantha, Alexis was asking if you could repeat that for her, please.
Oh, sure, sorry. So the expectation is like 4 meaningful touches. So we'll have that completed with the member, and we will have it correctly authorized. So it's an authorized member, the meaningful touches are there, and then it's denied. And we'll resubmit thinking it's a system problem, and it gets denied again. So we're not sure what's going on with that.
Okay. Okay, thank you for repeating that. So we're going to skip over interactions now, and we're going to move over to improvements. So let's go to the improvements row, if we can, Shiva. So the opportunities for improvement row, okay. So, let's take a few minutes for folks to please share specific processes. Here are best practices that, can help us overall improve in this area. So let's take a few minutes for each column along that row of opportunities for improvement to fill that out. Samantha, is that a question or comment about updated authorization trainings?
It's a request.
Okay.
Sorry.
That's okay. Okay, great. So we're getting some progress there. We've got a few minutes left. If folks could, let's try and get our comments wrapped up on that so we can just get to one more important section. Okay, we have a comment here from Nye regarding single point. Is that single point of contact or single point of entry?
That's for column C, row 22. Under opportunities for improvement. I just was hoping for clarification there.
Alexis, what would you say about that for opportunities for improvement under member referral? Is that single point of contact or single point of entry?
I typed that in. That was a single point to be referred. So in other words, almost like a system, like was it find help, where local CBOs and or MCPs or health providers have a single entry point that they can key information in, that referral then goes to an ECM or CS provider.
Okay. Thank you for that clarification, Casey.
Yeah, thank you, Casey.
You're welcome.
Okay, I see that Ashlyn's giving us a few more minutes. John here stated referrals receiving more from different sources, MIF, find a way to get updated client information, outreach, more staff to provide outreach, enrollment, more staff, authorization, easier process, claims. I'm curious, I appreciate those comments, John. Is that, are these issues ones that folks think can only be solved with more staff, or are there technical solutions? Are there solutions in terms of infrastructure that could help there? Any thoughts on that? Any comments?
You want more clarification on why I put more staff in regards to member enrollment and authorizations?
I'm not clarification, but I just wanted to get perspective from other folks in the room on whether or not the only sort of ways to solve those issues are with more staff, or if there were potentially technical solutions that could assist there. Just posing the question. Nai, you had your hand raised?
Yeah, I just wanted to share some background. So I've been working in Medi-Cal for, I think, almost 20 years. And unfortunately, what we've seen that's true in the couple of decades is that Medi-Cal members are very fluid. And so the contact information that they include on the application, by the time health plans receive the member file, the information becomes obsolete, right? And then sometimes what happens is they have cell phones where they may not have unlimited plan. They may have plan where they have a limited number of minutes. And so what happens is sometimes they turn off their cell phone, so they're unreachable. So this is a real challenge for all Medi-Cal members, regardless of whether they're assigned to Health Net or Health Plan of San Joaquin. And so I see solution at two different levels. One might be at a health plan level, where we are, a Health Net as an example, are trying to figure out a technology solution, working with third-party vendor that can help us ascertain any updated cell phone numbers, because we know that that's really important. And then the other opportunity is, and I don't know whether there's any time here with this cohort to discuss, but figuring out creative ways to find current phone numbers. So I'm just gonna, give one example, like an FQHC that sees patients. Oftentimes those medical intake forms or medical history documents, that they tend to collect current information, right? Because when they are providing physicians, doctors information, they tend to again be a little more transparent about their availability and their contact information. So if there's ways that your organization, because of the partnerships, because of kind of information that's collected, right, or can be collected, I would just really say that there's some opportunities there that we may want to leverage. And yes, we can give out cell phones because there's a Lifeline program where they do offer no cost, unlimited talks and texts with limited data. So there's those available. But again, we're talking about, large percentage of Medi-Cal members. that's, more than 60%, that, where we don't have current information. And it's not because health plans, we don't have access to it. It's really that information is captured on the state application form. So I just wanted to provide some of that background.
Appreciate that. Thank you so much, Nye. We'll get to Casey real quickly, and then we'll try and get that one last section. Go ahead, Casey.
Yeah, this might be way too big of an ask, but is there a way we can push this up to DHCS or the state where when they're completing an application, because part of ECM is to provide service where they reside, even if it's homeless or areas that they frequent or they receive care, can we start asking or getting that information from these members? Because I have not a problem sending staff out or going out myself if I know roughly where someone's going to be to try and connect with them to get them supported in services.
So the state is well aware of this. The
Okay.
state is well aware that they're not collecting accurate race and ethnicity and language information as well.
Okay.
Their system is really old. I mean, their system is like, it's like, it was implemented back in the 90s. And so they have technology issues, in addition to unable to, their inability to get more current information from individuals. And quite honestly, someone may have a phone number, right? They're borrowing someone's phone number. We see DPSS as an example where they use an address as a placeholder, but they don't live there. It's an office building, right?
Right.
So these are real challenges of Medi-Cal lives. And so, it's just, it's nature. It's part of the challenges our members have, right? So.
No, I agree.
Thank you,
I
Casey.
appreciate that.
No, and I appreciate you bringing that up because that makes sense, but the state is limited as well too.
No, I understand, and I'm sure updating the system would be quite expensive, but we can always ask, right?
So I appreciate both of you for your input on there. Okay, so it looks like we are going to move on to next steps. So let's go to the go back and go to the next slide if we can. All right, so we've got 60 seconds. So homework is to do the PDSA, which stands for Plan, Do, Study, Act. Okay. So we want to make sure that folks are, making a plan to plan, try, observe results, and acting on what we learned. Based on the feedback we received today, we will provide specific tests for your organization to consider. Okay, so please work with your team to build a plan to adopt and implement tests shared. Carry out the action and document of what you did. All right, this is the do portion. Capture problems and unexpected observations and begin an analysis of the outcome. Okay, study it. Did it work? What was the outcome of your effort? Summarize and reflect on what you learned, and then act. All right, whether we should standardize it. Okay, so based on what you observe, prepare for next steps. Next slide. Okay, so a little bit more regarding the PDSA and just what information we came up with today after today's session. We're going to review all of your feedback, in particular with the plans, in order to propose recommendations, and we will share those via email. Okay. And please be sure to complete the plan portion of the PDSA with your team to determine which test of change your organization will prioritize. Okay. And so be prepared to come back to the next collaborative, which is being held on June 26th. Okay. So that we can discuss that plan. And remember, we'll also be doing some of that journey mapping with community supports. Be on the lookout for the registration link and an email next week. All right. Also, we will be having more office hours. So that's, again, the third Thursday of every month. Next one is taking place on Thursday, June 15th from 1 to 2 p.m. Pacific Standard Time. Okay. I think a recurring calendar invite has already been shared via email. And if you have not received this invite, please email the project coordinator Shiva at healthbegins.org. Any questions on any of that? Any comments? Next slide. Okay, so part of how we're going to measure progress is looking at baseline measures, progress with process adoption, completion measures, and self-reported impact of improvement strategies. So I think we're
Theo, question, can you go back to the previous slide when it was office hours for next, on the 15th? From 1 to 2?
yes.
Officer, okay, perfect, thank you.
Okay, right. The next office hours being June 15th. It's always the third Thursday. Okay, Ashlyn?
Next slide, please. We've talked about how we'll measure progress. You can skip this slide. Go ahead and skip that slide. Skip that slide. Skip that slide. All right. Oh, sorry. All right. Very quickly, which improvement area are you going to commit to? And please select as many as apply, and the poll will launch.
Sorry guys, I'm having some technical difficulty launching the poll right now.
That's okay. We can go ahead and we can do the poll at the next convening next month. So let's just go ahead and keep moving. I don't want to keep people over. Okay, we've already talked about the need to both implement immediate solutions and also chronicle long-term changes. Next slide. Next steps. So we've talked about next month's session. In terms of homework, please complete your PDSA. Again, office hours are the 15th from 1 to 2. Please make sure to come. It's a great party. We're going to send you the materials and you can access them through the shared project folder. If you have any questions, you can reach out to the incredible Shiva and spread the word and keep thinking about who those trusted messengers are. Next slide. All right. Much appreciation for all of you, for the amazing Health Begins team that makes these meetings happen. I hope you all have a wonderful rest of your day and go ahead and listen to those favorite songs that you mentioned at the top of the call. See you all next month. Bye-bye. All right. Is there a new
debrief link?
uh-huh.
Let me check really quickly. I don't think I had created one.
Can we just stay on here and maybe stop recording?
Yeah, why don't we do that? Where did Alexis go?
Alexa.
She just jumped. Does someone want to ping her on Slack?
Oh, Alexis asked if we can debrief next week. Would you guys be comfortable doing that?
Yeah, of course. For
Will
sure.
will it all stay in our minds?
Yeah, it's fine.
Yeah, no worries. Thank you guys so much for, I just realized also because Pauline messaged me, it's because we were in the breakout room that I wasn't able to launch the poll. And we didn't go back to the main room because everybody was in the breakout room. I kind of forgot about that.
That's why that was
yeah.
my fault because
No, we're totally good. Everybody was in this breakout room and I just completely forgot that we even had the other breakout room.
Yeah, totally. Okay.
All right. Well, thank you guys so much for your help. That was a great session.
Great. Thank you, friend.
Thank you
Talk to you
guys.
soon.
See you
All
soon.
right, bye.
Okay.